Hello, I'm Jonathan Kay, reporting from ACR Convergence 2024 in Washington, D.C. Here on the second day of the meeting, I'm with Professor John Isaacs of Newcastle in the United Kingdom, who presented poster number 1349 about withdrawal of therapy from patients with rheumatoid arthritis taking conventional synthetic DMARDs. And you developed a molecular signature that predicts flare among patients in whom therapy is withdrawn.
Yeah, that's the case. Well, it was a circulating biomarker signature, and we increasingly achieve remission in patients with early RA on simple drugs like methotrexate, maybe with some hydroxychloroquine, and patients are starting to ask us whether they need to take these drugs for the rest of their lives. Traditionally, we've always said yes, but because we're being asked more and more, we've started to set up studies to find out what happens when we stop drugs. And actually in that population, if we do stop, then 50% of patients flare and 50% of patients stay in remission. The ones who flare, we can readily re-achieve remission with a shot of steroid and putting them back on the original drug in most cases. But what would be really cool is if we could develop a signature which tells us when it's safe, in inverted commas, to stop that treatment.
And the biomarker signature that you derived was what?
Yeah, it's three circulating mediators. One of them is an acute phase reactant, S100. I'm going to say 3A. I forget the exact name. There's an IL-6 receptor, and the third one I'm struggling to.
MMP9.
MMP9. That was what it was. That was right. So there's an interesting three biomarkers. You wouldn't necessarily associate them with prolonged remission, but they seem to predict.
And this was a prospective trial, and it's difficult to enroll patients in trials, but if you're telling patients that you're going to find out whether you can predict flare if they stop their drug, they must be excited about enrolling in a trial like that.
I've never found it so easy to recruit to a trial in my entire career. Patients were knocking on our door to take part because they don't want to take their drugs. And so we were way ahead of our recruitment target. So it was a nice study to run.
So with this molecular biomarker signature of MMP9, S100, 3A, and the IL-6 receptor, if you find this signature, you could predict which patients might flare upon withdrawal of therapy, and you might not withdraw therapy from them. But if they don't have this signature, a negative predictive value of lack of flare would be very helpful.
Yeah, that's right, and we validated it actually on a separate cohort. So we've done this twice now, and it validates area under ROC curves about 70%. So it's good enough, I think. And you're right. So if we then were to prospectively apply that signature, we would avoid flares in about 50% of patients.
And this is the type of biomarker panel that is useful in patients with rheumatoid arthritis, a panel that predicts which patients do not need to continue therapy, whether patients might not respond to a TNF inhibitor with a genetic signature, or in this case with a biomarker signature, patients who might flare if they were withdrawn from their therapy. So this is very exciting, and for more information about this and other presentations at ACR Convergence 2024, go to rheumnow.com. I'm Jonathan Kay.